So our next topic is gynecologic, oncology featuring Wenora Johnson, Lynch Syndrome, colon and endometrial cancer survivor, and Noah Kauff, Chief Cancer Genetics at Northwell Health. Dr. Kauff is a gynecologist and geneticist who has specialized in cancer genetics for over 20 years, which means he got into it at 10. A live question and answer period will be held following the presentations from Wenora and Dr. Kauff. So once again, submit your questions in the chat feature on Zoom. If you are listening on Facebook, we will do our best to get to any questions submitted in the comments section as well. But I am enjoying the conversations taking place on Facebook Live. Keep going, guys. So Noah and Wenora.
Hi, my name is Wenora, and I am a 3-time cancer survivor and Lynch syndrome patient. In February of 2011, I was diagnosed with stage 3B colorectal cancer. This particular cancer was diagnosed actually through a simple FIT test given by my primary care physician. And I have to say, it's the one that really saved my life. When that FIT test was given, I actually set it to the side for a couple of weeks until I received a call from my nurse practitioner that said, "Hey, Wenora, are you going to turn in that FIT test? The doctor needs it." And I was like, okay, I'll do it. And when that FIT test came back positive with small traces of blood, that then led to a colonoscopy, that then led to surgery, and waking up from surgery and being told that you have cancer. And not only do you have cancer, you've had it for 15 years. That was a wake-up call because I always thought I was a healthy person. In fact, I had just served 8 years in the United States Navy Reserves, and anyone who served in any kind of military capacity understands that you're getting all kinds of testing and shots and things to make sure that you are healthy. So I felt as if I had let myself down because I did not find this cancer and it had been there so long. So I went through the regular standard treatment for colorectal cancer, the chemo, and after treatment, 3 or 4 years out, I had no evidence of disease. And I was pretty happy with that. My oncologist, however, kept harassing me and saying, "Wenora, I think you're Lynch syndrome. I really want to get you tested." And I just would tell her, "But I don't have any cancer right now. How can I, be a Lynch syndrome person?" And she said she suspected it from my history that, a grandfather who passed away from colorectal cancer and a mother who passed away from a glioblastoma, that I was indeed maybe Lynch syndrome. And so I decided to finally have the genetic test. And when I had the genetic test done, it came back positive that I was indeed Lynch syndrome. In fact, not only that, it stated that I had an 80% chance of getting endometrial cancer within those next 5 years. And I thought, wow, this was my opportunity to do something about that. So I talked with my oncologist and my gynecologist and decided that we would schedule a total hysterectomy and that I would then just follow any other treatment plan from there. Well, after having the total hysterectomy, I had a biopsy, and the biopsy stated that I had indeed already had stage 1A endometrial cancer. Talk about a wake-up call again. I'm like, so this is what Lynch syndrome is all about. It's very real, and it's a gene mutation that causes cancer, especially for women in those gynecological areas. My particular mutation was MSH2 on the gene ladder, and this means that my children have a 50% chance of getting this mutation as well. And they are women, so I want to be able to talk to them about the importance of, getting tested on a regular basis. However, they just look at me as plain old mom. Mom's preaching her word. But this word is very vital for other young women and others who are maybe of Lynch syndrome to understand that this cancer, it mutates and it keeps mutating. And in fact, in 2017, after the all clear from the second cancer, I had a third bout of cancer. And that particular cancer was found by my dermatologist, and it was just a small fluke. I had a small pimple on my back. It was irritating enough that I tried ways to get rid of it, including an old-fashioned way of taking a pinprick and pricking it and hoping it goes away. But when it didn't go away, I decided it was definitely a time for a trip to the dermatologist. When I came to the dermatologist this time, I knew that I could tell her and say, hey, I'm Lynch syndrome, and just to let you know, it could be cancer. She didn't seem to think so, but I, however, stayed on top of it and told her that I know my body and that this is just something not in the ordinary, and just please be on the lookout for it. So test extensively. Well, after this minor surgery of what she called, that she was just going to cut out this small sac of oil cells that she referred to, she actually wound up digging out about 2 inches of basal cell carcinoma. That was another bullet that I had just dodged. So for me, Lynch syndrome is very real. I will be always looking over my shoulder and in front of me, always for future care and treatment, and especially when it comes to the gynecological portion of it, because for me, even though I had a total hysterectomy to remove the endometrial cancer, and that's all the additional treatment that I had to do, I'm still left with the after effects of that. So that means I'm thrown into early menopause and having issues with hot flashes and all those good things that comes with early menopause are things that concern me. And again, like I said, that 50% of this mutation gene being passed down to my children, it's a concern. So what I'm hoping is that Lynch syndrome keeps getting the deserved attention that it needs, and that we as Lynch syndrome patients are 30% more exposed to additional cancers in our lifetime, and it's very real for us. So I'd like to thank you for listening to my story, and hope that in some kind of way that Lynch syndrome will continue to be researched, and that we have better treatment options. So I hope to talk to you again soon.
Good afternoon. My name is Noah Kauff. I'm Chief of the Cancer Genetics Service at Northwell Health Cancer Institute in New Hyde Park, New York. I'm also a board-certified obstetrician and gynecologist. This afternoon, I'm going to be speaking to you about gynecologic considerations in Lynch syndrome. I'd like to thank the meeting organizers. I'd also like to sincerely thank Wenora for sharing her story, as it raises a number of important topics which I'm going to be touching on in the next 20 minutes. I'm just going to share my slides. And as I mentioned, we're going to be talking about gynecologic considerations in Lynch syndrome. Quickly, a couple of disclosures. I have served on advisory boards for AstraZeneca and Merck, and I've received honorarium from BGI. In terms of the topics I'd like to touch on this afternoon, I'd like to mention gynecologic cancer risks associated with Lynch. I'd like to discuss some new methods of identifying individuals at risk for Lynch syndrome, review options for gynecologic cancer risk reduction, and also discuss options for treatment of symptoms and sequelae of gynecologic cancer risk reduction approaches. First thing which I'd like to touch on are the gynecologic cancer risks associated with Lynch syndrome. And importantly, when we think about it, it's important to remember that Lynch syndrome is caused by mutations in 5 different genes. And while each of these causes mutations in each of these genes causes a related syndrome, they are distinct and they have distinct cancer risks. And this is going to be important as we think about timing of cancer risk reduction strategies. When we first did early research looking at cancer risks associated with Lynch syndrome, we frequently lumped together all of the Lynch syndrome genes together. First, just MLH1 and MSH2 together, then we added MSH6, and more recently, PMS2. But in the last 5 to 10 years, we've begun to realize that each of these genes causes distinct cancer predisposition syndromes with their own risks. And as we talk about gynecologic cancer risk, we can actually see that the risk of uterine cancer is substantially elevated for individuals with mutations in any of these genes. But it's actually highest for individuals with MSH2 mutations with a lifetime risk approaching 50%. A little bit lower, but still markedly elevated in MLH1 and MSH6 mutation carriers of about 40%. But for PMS2 mutation carriers, the lifetime risk is only about 13%. And this compares to about a 1 in 37 lifetime risk in the general population, or just about 3%. As we look at ovarian cancer, we again see that MSH2 has the highest risk of ovarian cancer, 18%. MLH1 and MSH6 have somewhat lower risk, lifetime risk of about 11%. And when we go to PMS2, a lifetime risk of only about 3%. This compares to about 1.3% in the general population. So increased, but not by a huge amount. And again, this is going to be important as we talk about what we should be doing for risk reduction, and interestingly, when we should be doing risk reduction. The other thing which is important when we think about when is, although we see these hugely increased risks of gynecologic cancer, you don't go from having zero risk on your 35th birthday to 1 day later having a 49% risk of developing endometrial cancer and 18% chance of developing ovarian cancer. Instead, this was data that came from Paul Mahler's group about 3 years ago that were looking at the age-specific risks for uterine cancer in Lynch syndrome. And you can see for MLH1, MSH2, and MSH6, in all three of these, the cancer risks begin to pick up in the mid-30s and then continue throughout life. However, in the setting of PMS2, really the endometrial cancer risks do not begin to appreciably increase until about age 50. And this is going to have important implications as we talk about timing of risk reduction strategies. One other thing to keep in mind is you're not just at risk for one cancer, but can be at risk for multiple cancers with Lynch syndrome. This is a study that actually goes back almost 20 years, but showed that individuals with Lynch syndrome who already had cancer have about a 30% risk of developing a second cancer in 10 years, and this increases to 50% in 15 years. And Wenora is a wonderful example of this, where she was initially diagnosed with her colorectal cancer at 45, but then had her endometrial cancer at 50. In terms of, is there any particular likelihood that you'll either develop colorectal or endometrial cancer first? And for many years, it was actually thought that you were at much higher risk of colorectal early on. But when we've actually done studies looking at women with Lynch syndrome who actually had both colorectal and gynecologic cancer, about an equal number presented with gynecologic cancer as opposed to colorectal cancer. And importantly, irrespective of if you presented with gynecologic colorectal cancer, there was an average of 8 to 11 years between your first and second diagnosis, suggesting that if we use that time to identify individuals at risk, we could actually do something to potentially prevent that second diagnosis. So how do we identify individuals with Lynch? Well, the standard has been family history, where we're looking at individuals with early onset colorectal and endometrial cancer, or a combination of colorectal, endometrial, and other Lynch syndrome case in the family. And while that is still incredibly important, something which has actually occurred over the last 5 to 7 years is an increasing understanding that there is a large enough fraction of individuals with colorectal or endometrial cancer who have Lynch syndrome that we should be actually evaluating anyone who has colorectal or endometrial cancer for the possibility of Lynch syndrome. And what we can do is do that by testing all uterine and colorectal cancers for a marker that is seen in essentially all Lynch-associated cancers. This is a marker that is actually called microsatellite instability, and it is something which basically any Lynch-associated tumor will show. Importantly, there are other reasons why you can get microsatellite instability, and about 3 out of 4 colorectal and endometrial cancers which show microsatellite instability do not have Lynch syndrome. But if we show that this doesn't exist, we can actually almost conclusively rule out that Lynch syndrome caused a particular cancer. The reason this is important is there are now multiple professional societies, including the American College of Obstetrics and Gynecology and the Society of Gynecologic Oncologists, as well as the National Comprehensive Cancer Network, which suggests that all individuals with colorectal and endometrial cancer be evaluated with tumor testing for the possibility of Lynch syndrome. And the reason why this is important is when Wenora was diagnosed in 2011, this was not the standard approach. But if she was actually diagnosed in 2020, we would have been able to identify that her tumor was suspicious for Lynch and gotten her to genetic counseling and testing before the 5 years that it actually took her to get for testing. And in fact, it may have given us the opportunity to do a risk-reducing hysterectomy before her endometrial cancer ever developed. Additionally, it will allow us earlier identification of families at risk. Wenora has 2 children. Both are daughters, and they could also be at risk for Lynch-associated cancers. And although the gynecologic cancer risks don't start until really the early to mid-30s, as you know, the colorectal cancer risk can start in the early 20s, which is why we recommend that individuals with Lynch syndrome begin screening in their early 20s in the setting of a known mutation. So if we have someone who has Lynch syndrome, what can we do to reduce these risks of gynecologic cancer, of endometrial cancer of up to 50%, of ovarian cancer of up to 18%? We actually have a number of strategies. First, we have screening. And when we talk about screening, I'd like to break it down to uterine screening and ovarian screening. In terms of uterine screening, probably the most important screening is to screen for menstrual irregularities or postmenopausal bleeding. Now, how do we look for menstrual irregularities? Well, it turns out most women actually do not have a menstrual cycle that is every 28 days like clockwork. Anything from having a menstrual flow every 3 to 6 weeks can be normal. But what we are looking for is that you're having a flow every 3 to 6 weeks. And when you do have flow, it is of similar character and duration to your normal flow. Things that will actually make a gynecologist concerned in the setting of Lynch syndrome is if you have bleeding closer together than 3 weeks from the beginning of one cycle to the beginning of the next cycle, if you have bleeding or spotting in between your cycle, if you have a noticed change in character, increased flow, or increased duration of your flow, those are things you want to bring to your gynecologist's attention. The best way to track this is to keep a menstrual calendar. And it can be on a paper calendar or it can be on an app, which you just record any day that you have bleeding or spotting. It's the first thing your gynecologist is going to want to review if you think you might have abnormal bleeding. Similarly, if you're postmenopausal, any postmenopausal bleeding or spotting needs to be evaluated. Other things that we can use is endometrial biopsy, which is a random biopsy of the endometrium. This can be done in the office. It takes about 2 minutes. It is a little bit uncomfortable, though we can pre-medicate with things such as Motrin, which will help to alleviate some of this. And although we don't have data that this clearly reduces the incidence reduce the incidence of uterine cancer in Lynch syndrome, we do have early data suggesting that it does detect precancerous lesions in a significant number of women with Lynch syndrome. In terms of ultrasound, the data is less clear. We do know that for women who are postmenopausal, there are some people who advocate using transvaginal ultrasound to look for the thickness of the uterine lining. The postmenopausal years, it should be less than 4 millimeters, and something larger may be something that justifies evaluation. However, importantly, transvaginal ultrasound is not a useful method for screening of uterine cancer in premenopausal women because of normal significant variation in the uterine lining thickness. In terms of ovarian cancer, as you're aware, ovarian cancer, we do not have really effective screening for. Transvaginal ultrasound and CA-125 have been investigated, but they have not been found to be beneficial. That being said, are there some things that we can do? Yes, we can actually screen for symptoms of ovarian cancer. And although for many years we thought ovarian cancer was a silent disease, it's actually a subtle disease. It does have symptoms, most commonly pelvic or abdominal pain, bloating, early satiety, increased urinary frequency or urgency in the absence of an infection. Now, these are common symptoms, and almost all women will have these at some point in their life. But what we're specifically looking for is something that is a change from an individual woman's baseline, is occurring almost every day, and is lasting for more than 2 or 3 weeks. In the setting of any of those, you want to bring them to your gynecologist's attention. What about prevention of strokes? We have 2 different major approaches to prevention. One is chemoprevention, which is medications to reduce the risk of cancer. And interestingly, some of the chemoprevention approaches that we have actually are likely to reduce the risk not only of uterine, but also ovarian cancer. Most important of these is oral contraceptives. Oral contraceptives in the general population, 6 to 10 years of use, will actually reduce your lifetime risk of ovarian cancer by as much as 30 to 60%. And there is early data in women with Lynch syndrome that we may actually have improvement in at least intermediate biomarkers of uterine cancer. Similarly, an intrauterine device that contains the hormone progestin may actually also be associated with protection against endometrial cancer. It turns out we use this initially for contraception, but we now actually use this for treatment of precancers, or in fact, even early cancerous changes of the uterine lining in women without Lynch syndrome. And there's data from MD Anderson to suggest that this approach may be effective in women with Lynch syndrome. Importantly, I have not put the injectable progestins here. And although they likely may protect against uterine cancer, there are a couple of issues that make me really not want to use it in women with Lynch syndrome. One is they're frequently associated with irregular uterine bleeding, which can cause worry and workup and potential workup in women with Lynch syndrome. The second thing is they can be associated with an increased risk of osteoporosis. And since many women with Lynch syndrome will ultimately have a surgical menopause somewhat earlier than they would ordinarily have a natural menopause, which will increase their risk of osteoporosis, I would like not to further compound that risk with the injectable contraceptives. The other options which we have are risk-reducing surgery. And that risk-reducing surgery can be hysterectomy alone or hysterectomy with removal of the fallopian tubes and ovaries, what we term bilateral self-oophorectomy or BSO. Certainly, the uterus is the major organ at risk and is something which we want to consider removing because, again, we're not really clear how good our screening is. And we have excellent data that hysterectomy does reduce the risk of gynecologic cancers and Lynch syndrome. But this is where it's important that we look at not only what are the lifetime risks of uterine cancer, but when are those risks. And as I showed you a little bit earlier, in most cases, the risks do not actually even begin until we get into the middle to late 30s. And so it gives us time for women to complete childbearing with perhaps undergoing gynecologic cancer screening. And once they've completed their childbearing, consider removal of the uterus. In terms of removal of the ovaries for MLH1, MSH2, and MSH6, there is an appreciable increased risk of ovarian cancer, and we have limited screening options. So we likely are thinking about removing the ovaries as well, and this is actually where this induction of surgical menopause occurs. However, when we look at women with PMS2 mutations, they have really a very small increased risk of ovarian cancer over their lifetime, and it may be reasonable to defer the removal of the ovaries in those women. However, if we are considering removal of the uterus and ovaries, this is associated with symptoms. As Wenora mentioned, she is having menopausal symptomatology, and up to this point, she's really just been toughing it out and living with it. The question is, do we have to do that? Certainly, most women who have an early surgical menopause will have some symptoms. They can be hot flashes, night sweats, vaginal dryness. However, there can be hair changes, skin changes, mood changes. Though importantly, although most women will have some symptoms, I cannot predict how severe those symptoms will be. For some women, they'll say, "Oh, this is all there was to menopause. What was I worried about?" For other women, the symptoms can be devastating. And for most women, they're actually in between these extremes. But importantly, we have options that can proven options that can improve these symptoms in the vast majority of women. In terms of the vasomotor symptoms, the hot flash and night sweats, we can use behavioral changes, just as simple as dressing in layered clothing, such that if you have a hot flash, you can pull off a layer. It can be having a fan at your desk. We have non-hormonal medications that have been tested actually in women with hormone responsive breast cancers in both the antidepressant class and the anti-seizure class, which have been shown to reduce both the frequency and severity of hot flash and night sweats in about 2/3 of women. And because Lynch syndrome does not appear to be associated with a significantly increased risk of breast cancer, we can even talk about hormonal options, including systemic estrogen. In terms of vaginal symptomatology, we can use things such as lubricants and moisturizers, low-dose vaginal estrogen, systemic estrogen, and then something which many women are not aware of is we can actually do physiotherapy of the pelvis, which is actually helpful for many women with menopausal symptomatology, be it surgical or even natural. In terms of the other menopausal sequelae, as we said, if you do have an early surgical menopause, it can increase the risk of osteoporosis. But there are things we can do to address this. First of all, I recommend that women who have a risk-reducing surgery have a baseline bone density shortly thereafter. I like to make sure that we assure adequate calcium and vitamin D supplementation. And we have medications, both non-hormonal ones such as bisphosphonates or estrogen, can actually help protect against osteoporosis. Lastly, there is a concern about whether or not early menopause may increase the risk of cardiovascular disease. And the data on this is actually still unclear. But that being said, I think any woman who has a risk-reducing surgery with early surgical menopause should actually address modifiable risk factors for cardiovascular disease. That includes addressing high blood pressure, increased cholesterol, diabetes, and if you're smoking, making every attempt. So in summary, over the last 20 years, we have had tremendous improvement in our understanding of the gene-specific gynecologic cancer risk, and this is allowing us to better tailor risk reduction strategies to the individual women with Lynch syndrome. We are also making strides in identifying individuals at risk and actually far better identifying patients such that they are not at risk of first or second cancers. We have proven options for reducing gynecologic cancer risk if we can identify the women are actually at risk. And lastly, although some of our risk reduction options are drastic and do have symptoms and sequelae, we also have proven approaches to actually reduce these symptoms and sequelae. I want to thank you for your attention. I look forward to your questions, and I hope you enjoy the rest of your conference.
Thank you, guys. You guys were really good. I hope everyone was able to hear all of it. I know we had a little bit of muffling, but I think it was all pretty legible. So Noah and Wenora, I think you guys are the big winners because we got a bunch of questions coming in. So I'm gonna fire them off as quickly as I can, and we'll try and stay within as much time frame as we can. If we need to go over, hopefully they'll bear with me a bit. So a couple of questions. So no, somebody is talking about having pre-implantation genetic disorder testing. Can you real briefly talk about what PGD is and you know what it can do for somebody?
Okay. PGD is a process that allows us, in the context of an in vitro fertilization cycle, do prenatal diagnosis for a known Lynch mutation, such that if there's a known MLH1, MSH6 mutation in the family, you can actually do, as part of an in vitro fertilization cycle, actually test an embryo. Now, interestingly, many people are not aware, but when they actually go through in vitro fertilization, we frequently don't just fertilize one egg, but we actually fertilize a number of eggs, frequently on the order of 5 to 8 embryos, and create 5 to 8 embryos, which are grown until the 5th day of life, of embryonic life. Using a variety of criteria which are designed to determine which of those embryos is most likely to result in a successful pregnancy, we put those most likely embryos back into the uterus at day 5. Somewhat amazingly, at day 3, when the embryo is 8 cells, you can remove 1 cell from the embryo without damaging it. And in the setting of a known mutation, you can actually test that embryo to see whether or not it shares the familial mutation, and use it as one of the selection criteria as to which embryo goes back. Now, this is something which 15 years ago was science fiction, and now is actually, from a technical standpoint, not that difficult. That being said, there are challenges. One is in vitro fertilization is work. No one enjoys the process. It is a full-time occupation for women who have gone through it. 2, there are non-trivial costs, and they are variably covered by insurance carriers. 3, some people even enjoy getting pregnant the old-fashioned way. You can't do this when you do that.
Sure.
But what is probably the most important thing is I think we need to discuss this with any woman with Lynch syndrome of reproductive age. And importantly, this can also be for men who are fathers who have Lynch syndrome, who are considering pregnancy, because again, we can test for paternal Lynch mutations as well in the embryo. But something which is, I think, important. The first Lynch syndrome genes were identified in the early 1990s. We have learned a huge amount in the last 25 years regarding both risks of Lynch, but also what we can do to reduce the risk. And now we have proven strategies to reduce the risk and actually get life expectancy for patients with known Lynch syndrome very near the general population. If you actually even are pregnant today with a child who has Lynch syndrome, we have at least 2 to 3 decades before there are any risks to that child. And although we've learned a huge amount in the last 25 to 27 years, by the time there are risks for that child, our conversation today will be the dark ages. And if the best I have to offer those potential children is what I'm talking to you about today, all of us who do this for a living are going to be very sad. I think it's an important option to have people be aware of, but importantly, the vast majority of my patients with Lynch syndrome actually don't take advantage of it. That being said, I have had several dozen who have, and they've been very happy that they have. So I think it's an important option to discuss.
Thank you, Noah. That was great. And yeah, it is a process, and it is expensive and consuming and emotional, like anything. But thank you for that. So a couple other questions, and I'm not sure if it's because it's Breast Cancer Awareness Month, but I got a couple of questions regarding breast cancer. Someone who had breast cancer and has been attributed to Lynch syndrome, she gets a 3D mammogram yearly and wants to know if that is sufficient as far as screening. I'm assuming the question is regarding just a recurrence of the breast cancer, but I have to imagine other screening would be involved as well.
Okay. In terms of what is appropriate for the particular questioner, I cannot really give an intelligent answer, as I don't know the rest of her personal history, her family history.
Right.
She personally has breast cancer, and so those are all going to be things that play a part.
So,
Go ahead.
no, was there more?
Yeah. Although there is some data that has suggested that there might be a slight increased risk of breast cancer with some of the Lynch syndrome genes, this is controversial, and certainly not all of the data has confirmed it.
Right.
But even if that risk is there, it's probably best thought of that Lynch is probably a modifier of breast cancer risk, not causative. Different than, for example, a woman with a BRCA1 mutation who develops an early onset breast cancer, that we can in most cases say that but for that BRCA1 mutation, you would not have developed breast cancer. In Lynch syndrome, even if the Lynch syndrome genes play a role, they're probably working in a background of other genetic and environmental modifiers, and are actually part of the story, but almost never the whole story. And probably the biggest part of the story for an individual person is what is their personal history. For example, when was this individual diagnosed with breast cancer, but also what is their family history of breast cancer, even in individuals who don't share the mutation. And that's actually, it's really going to be their personal and family history of breast cancer, which is going to drive my recommendations for what they should be doing for screening, as opposed to the presence of the Lynch gene, which at the moment, even in the presence of a Lynch gene, we recommend that individuals screen as per the general population, not with incremental screening in 2020.
Got it. So, a similar question with what Wenora has gone through, and this is regarding having a hysterectomy. So if a hysterectomy and oophorectomy is done on a Lynch patient, I know, Wenora, if I understand correctly, you actually found your cancer after having the hysterectomy. Are there extra measures a pathologist should take in analyzing the tissue after a hysterectomy for a Lynch patient? This was a question submitted to me, so hopefully
Most importantly, the pathologist needs to be aware that there is a Lynch syndrome mutation. And the reason is there is certainly a much higher incidence of occult uterine and or ovarian cancer at time of hysterectomy and ovarian cancer if we're removing the ovaries. In terms of the process, obviously, and the reason which I say that is there are lots of ways to look at a uterus, and a uterus can actually be anywhere in the postmenopausal years from perhaps the size of a walnut to, in the premenopausal years, a normal uterus is likely more the size of an orange, but frequently can be a grapefruit, or with certain other conditions, much larger. And so in terms of looking at it microscopically, you sometimes can't look at every couple of millimeters of the uterus, but you need to have a much higher index of suspicion. And the thing is although you can pick your surgeon who does your risk-reducing surgery, unfortunately, almost none of us get to pick our pathologist.
you can never pick your pathologist.
Okay, and this is where it's going to be critical. And because you want to have pathologists who have an appropriate respect for Lynch syndrome and the possibility that there's going to be an occult cancer. And the only way which you can really do it, because you don't pick your pathologist, as much as I am a general gynecologist and I have tomatoes thrown at me whenever I say this to an audience of general OBGYNs, I actually think your surgery should be done by a gynecologic oncologist, which is a gynecologic cancer specialist at an academic medical center, where you have academic pathologists who are going to be thinking about it in a much more thoughtful way and likely going to look at the uterus more carefully. As much as you might have had experiences with your local gynecologist who's delivered your babies and it's convenient at your community hospital, for preventive surgery, I think it's worth the trip of going to an academic medical center, frequently the principal teaching hospital of a medical school.
You are going to have tomatoes thrown at you, Noah. You know that.
I know, every time.
Okay, so Wenora,
believe it.
When you had your risk-reducing surgery, did you have any inkling or any choice, if you will, of what was going to happen after, or if you don't mind me asking?
You know, my biggest thing is that I just didn't want to do chemo again. So after the surgery was done and they said, yes, there is endometrial there, though it's in a lower stage, that was the treatment option at that time. So for me, I was kind of like, ooh, I don't have to do chemo. But immediately, like I said, 2 days later, it threw me into menopausal symptoms. So struggling with those. And as Dr. Kauff mentioned, I've been suffering silently because I just thought this was just a natural process that got inflicted upon me a little bit earlier than usual. So now that I have choices out there that maybe I can talk with my gynecologist about for treatment for early menopause, I'm definitely going to be looking into those measures.
Awesome. So different question for Noah. For someone, is it recommended having a PAP done after a hysterectomy when someone had normal PAPs previously to the hysterectomy?
Okay. This is a question which you generally want to address to your gynecologist. However, for individuals who had an appropriate risk-reducing hysterectomy in the setting of Lynch syndrome, and what I say is an appropriate risk-reducing hysterectomy, that's what we mean by what we call a total hysterectomy. And interestingly, what gynecologists mean by total hysterectomy is different than what most people think about it. A total hysterectomy means that the uterus and the cervix, which is the lowest part of the uterus and is actually the portion that goes into the vagina, are removed. Total hysterectomy, interestingly, does not say anything about the ovaries and fallopian tubes, which if those are removed, it's a total hysterectomy with a bilateral salpingo-oophorectomy, or BSO. Now, there are some pros and cons for women in the general population if they are having a hysterectomy for leaving the cervix behind. In the setting of Lynch syndrome, I don't think that's appropriate. And the reason is there is no bright dividing line between the uterus and the cervix. So I actually think an appropriate risk-reducing hysterectomy is a total hysterectomy with removal of both the uterus and the cervix. If that has been done and someone has no prior history of abnormal pap smears, we actually do not recommend continued pap smear screening. And importantly, what pap smear screening is looking for is actually for cervical cancer or cancers related to cervical cancer, which are not actually part of the Lynch syndrome. And so it is actually entirely appropriate for you not to have pap smears. That doesn't mean you don't need gynecologic care. We just don't need to put the smear in the jar.
Awesome. So I guess a general question for Wenora. Any thoughts on the best way to get family members to get tested after you test positive? If you have any words of advice, I'm sure we would all welcome it because we're all in the same boat.
Wow. I wish I had a magical answer for you because I'm in the same boat myself. I have two young women who are, like I said, they're just looking at me as mom, and I'm preaching. And the one thing that I hope, and the takeaway comes from this, is that maybe one day they will hear someone else's story, or someone will talk to them, or when they have that next doctor's office visit, that light bulb moment will come on. Other than that, I will keep encouraging them. And that's what I suggest to everyone here. Just keep encouraging that family member that maybe at some point they'll change their mind and get tested.
And I'm going to follow up on what Wenora said here. Something which I've actually sometimes found helpful is not encouraging for people who are concerned about getting tested, is actually don't encourage testing. Encourage them to meet with a genetic counselor. The people who are deferring testing frequently have concerns about, which they have found because of speaking with people, because of going on the internet, some of which are likely valid and well-founded, and others are just more of myth and legend. And instead, I encourage my patients, if they have family members who are saying, I don't want to get tested, instead I said, meet with a genetics counselor or a genetics professional who can discuss what the testing can do, what it won't. No one is going to tie you down and pull a sample from you or a saliva sample and test you without your permission. But instead, have someone who can, in an expert way, at least address your concerns. And they may very well be valid. But say you going to a counselor doesn't mean you have to have testing, but you can have a more intelligent discussion. And that's sometimes been an intermediate strategy that I've found helpful with my patients and their family.
Awesome. Well, thank you, Noah, and thank you, Wenora.